Management of diabetes for geriatric patients in long-term care facilities. By the end of the presentation, students will be able to explain why sliding scale insulin is not recommended in the geriatric patient population residing in nursing homes. Jerry is an 82-year-old male who suffers from hypertension, dementia, and type 2 diabetes. He lives in a long-term care facility in Alpharetta, Georgia, and is completely dependent on the staff for his activities of daily living and medication administration. Jerry has a poor appetite, and the staff has been checking his capillary blood glucose twice daily and realized he is suffering from hyperglycemia. In long-term care facilities, 25 to 34% of residents suffer from diabetes. Patients in long-term care facilities suffer from a variety of comorbidities like Jerry. Choosing a correct treatment option is crucial to prevent further microvascular and cardiovascular complications. The medical guidelines presented by the American Diabetes Association, as well as the American Geriatric Society, American Medical Directors Association, and Choosing Wisely campaign have all agreed that sliding scale insulin is not the treatment of choice. Simple treatment regimens are preferred for this population. The Beers criteria has even recently added sliding scale insulins to the list of medications to not use in this population due to the high risk of hypoglycemia without properly managing hyperglycemia. Hyperglycemia is a major concern with sliding scale insulin, as it is not given in consideration to meals and sugar consumption. Since Jerry has a poor appetite, sliding scale insulin would put him at risk. Furthermore, sliding scale insulins have not been found to effectively meet insulin needs in this population and have shown greater patient discomfort and increased nursing time as more stringent monitoring is needed.
Rapid-acting insulin and bolus insulin closely mimic basal insulin and are more effective options than a sliding scale regimen. The use of oral agents demonstrate a much lower risk for hypoglycemia when compared to insulin. In addition, the ADA has less stringent blood glucose goals for those with multiple comorbidities and functional dependence. Typical A1C recommendation lies at 7%, whereas with Jerry, the preferred A1C range is between 8 and 8.5%. Due to Jerry's comorbidities and living environment, we need to choose a method to manage his type 2 diabetes. Based on medical consensus, we would not choose sliding scale insulin. Rather, we would choose an oral agent or basal bolus insulin as it follows the physiologic insulin production and manages blood glucose more effectively. It is imperative to work with an interdisciplinary team when developing a treatment plan in long-term care. To learn more about diabetes management in the geriatric population, we recommend using the ADA website and accessing their practice guideline resources.